Reverse engineering approach. This is a very useful approach, and I use this mostly for emergency scenarios. And this is how I use this approach. During this emergency scenarios, once you quickly read the scenario, you will get an idea whether it's an emergency scenario or not. So how do you know if it's an emergency scenario or not? Just by looking at the symptoms that are given in the scenario. Something like severe chest pain, severe abdominal pain, or is crying, or the patient is unconscious, or there's is not able to breathe, he's having extreme difficulty. When they use such words, it's most likely an emergency scenario. And this is how I deal when the scenario has got such words. The first thing I do is I will plan the scenario. So I'll just close my eyes for a second and plan the scenario. Okay, now it's an emergency scenario. So I will slightly use a different approach, which is slightly different to our traditional history taking approach. So the reason I use the word reverse engineering is you start the management first, then you ask the vitals, then you will go into history. This is something reverse of what we do usually in real life. So if the patient has got a chest pain or abdominal pain, first thing I do is I offer analgesia, so which is contrary to what we do in a usual scenario. Before I give analgesia, I will ask if he has got any allergies. Then I will ask the examiner if the patient is ill or well, and irrespective of the examiner's answer, I will ask for vitals of the patient. This actually tells the examiner that you are actually, what you're dealing with. You know that, you're looking if the patient is stable or not stable. So this is how I plan my emergency scenario. Then the third thing I do is I will guess what are the worst consequences that can happen with this particular scenario. For example, if it's a unconscious patient, or if they say the patient is unconscious, I will usually think about Glasgow Coma Scale, which is GCS there. Then I'll quickly close my eyes and just try to see what are the things we look in the Glasgow Coma Scale. Once you go into the room, when the examiner asks you those questions, or when you have to think about it because you are under pressure that the patient is there in the room or the examiner is in the room, so you will probably not think smart. So that's why I usually think about such things outside the room, things like Glasgow Coma Scale. I think about CPR guidelines, just in case in some scenarios the patient will become unconscious while you're taking history, then you should know how to do a CPR. Then I think about the doses of medications like doses of adrenaline, and other medications you give in CPR. This is because it makes your life easy, and I usually plan my emergency scenario like this. And this is, again, as I said, it's a brainstorming way. This is the best way of dealing with an emergency scenario. So know if it's emergency or not. Once it's emergency, do the reverse engineering, which is treatment first, then ask the vitals or findings, then you go to history. Once the patient is stable, you go and ask further history. I will probably stop with vitals only here. I will not ask the examination findings. I'll just stick to the vitals to see if the patient is stable or not, and that's it. Then I will take history. Okay, again, when you start history, you start with introducing yourself, asking open-ended questions, and routine way of history taking. I hope this helps a lot when you're dealing with an emergency scenario.